Hello everyone and welcome to Sketchy Medicine. Today we'll be talking about the all-important cardiac murmurs. Before we begin, we need to contextualize the murmurs based on the two heart sounds of S1 and S2. We can also break them down within the systolic murmurs or diastolic murmurs. Now, our first murmur to talk about within the systole phase is the ejection systolic murmur, which elicits a typical crescendo-decrescendo type of sound. You have the pansystolic murmur or hollow systolic murmur, which is a blowing type of murmur, most commonly known as. Then you've got the late systolic murmur. Within the diastole phase, you have the early diastolic murmur, followed by the late diastolic murmur. And then you have the murmur that is present throughout systole and diastole, and this is known as the continuous murmur. Now we'll talk about the most common murmurs and most important murmurs to know. With ejection systolic murmurs, you have aortic stenosis and pulmonary stenosis. Pansystolic murmur, you have mitral regurgitation as well as tricuspid regurgitation. Now we'll touch on late systolic murmurs a bit later. With early diastolic murmurs, you have the aortic regurgitation murmur, followed by the pulmonary regurgitation. With aortic regurgitation, this is exhibited also through various clinical signs. Patients will demonstrate a wide pulse pressure, which is a difference between the systolic blood pressure and diastolic blood pressure. They'll also have a collapsing pulse on examination, and they'll have physical signs worthy of note. There are many, but we'll just talk about three. First is Quincke's sign, which is pulsation of the nail capillary bed. You then have Corrigan's sign, which is a dancing carotid pulse, which you can observe at the bedside. And also you have de Musset sign, which is head bobbing. Whilst we're here, important to note that in aortic stenosis, you have a narrow pulse pressure. With the late diastolic murmurs, you have mitral stenosis, as well as tricuspid stenosis. Now with ejection systolic murmurs, you can have other conditions under this heading. These include an atrial septal defect, a hypertrophic obstructive cardiomyopathy or HOCM. You have normal physiological states that, for example, in patients that are thin, fit and athletic, or pregnant patients, and abnormal physiological states, and this can be in hypothyroidism, for example, or anemia. Now both normal and abnormal physiological states demonstrate a flow type of murmur secondary to a hyperdynamic circulation. So essentially, these murmurs are a result of valvular pathology. Now when we look at mitral regurgitation, this can eventuate into a mitral prolapse secondary to a papillary muscle rupture post-myocardial infarction. This can lead to Barlow syndrome. Similarly, tricuspid regurgitation can lead to or can eventuate into tricuspid prolapse. Now both of these prolapses are then put under the subheading of late systolic murmurs with the type of sound they emit. With continuous murmurs, you have patent ductus arteriosus, a pediatric congenital murmur. A central venous hum is another pediatric murmur, a flow type of murmur. And then you also have a mammary souffle, which is present in pregnant patients and is secondary to engorged vessels and not necessarily a result of valvular pathology. In the case of aortic regurgitation, it can become severe aortic regurgitation and elicit a Austin-Flint murmur, which is essentially a functional mitral stenotic murmur. There isn't any mitral valvular pathology, but it begins to demonstrate a sound similar to mitral stenosis and falls under and exhibits that late diastolic type of murmur. It's also important to note that the position of different murmurs coincide with different accentuations with respiration. The left-sided murmurs are loudest with expiration, the left side, capital E, and a right side with a capital I is loudest in inspiration. Whilst we're here, we'll draw a caricature of the thoracic cavity and label the sites of the aortic, pulmonary, tricuspid, and mitral valve. Good way to remember is all physicians take medication. Now with the radiation of murmurs, it's important to note that aortic stenosis radiates bilaterally to the carotids and best heard when the patient's leaning 45 degrees. You have aortic regurgitation HOCM, which is radiates to the left sternal edge and best heard when the patient's leaning forward. Mitral regurgitation radiates to the axilla and is best heard when the patient is lying in the left lateral position. Important to note that the Valsalva maneuver can accentuate the HOCM murmur, and this can be done by asking the patient to blow out forcefully through a syringe, and this increases the intrathoracic pressure and accentuates this murmur. Now with tricuspid regurgitation, this type of murmur, you'll have a V wave, and this is related to the JVP, and can be related to pulmonary hypertension. And features of pulmonary hypertension include a loud P2, a right ventricular heave, as well as a palpable P2 tap that's palpable. Now with VSD and ASD, these two murmurs are quite interesting. VSD falls under pansystolic and ASD falls under an ejection systolic murmur, but they're not basically accentuated with variations in respiration. Rather, they're accentuated when a patient lifts their leg or you lift their leg for them. This increases venous return and consequently accentuates this murmur. Now lastly, we'll talk about pulmonary stenosis. This is as rare as hen's teeth. And if we were to talk about tetralogy of Fallot, we would have to ask ourselves, or you'd have to prove to me that you know it. And P is for pulmonary stenosis, R for right ventricular heave, and O for overarching aorta, with V representing ventricular defect. Now, in a patient with a pulmonary stenosis, you'll be considering their past medical history and also considering whether they've had this in the past, i.e. tetralogy of Fallot, and as a result may have had postoperative complications resulting in the resurfacing of pulmonary stenosis. That's it for us today. Thank you for your time.